the question that we all have is, do we have blockage? That's kind of what everybody wants to know. Well, this could be a real short talk because, yes, we all have blockage, okay? But the real question is that what does all that mean? Why is heart disease the #1 killer of men in this country? And so what do we do about it? So let's just look at some of the cardiovascular statistics for men. Coronary disease, stroke remain the leading cause of death of men in America and most developed countries. And since China has developed the second biggest economy, their cardiovascular disease has just gone off the charts. It's over 30% of all male deaths in the U.S. happen because of cardiovascular disease. It's #1, it's been #1, and it's probably going to stay #1. In 2012, there were 812,000 people that died of cardiovascular disease. #2 was cancer at 565,000. So just to give you a little graphic to see, it's quite a bit more problems with cardiovascular disease. And this really lumps in heart attacks, heart failure, all those types of things. Stroke is actually teased out, and it probably would be even higher. This is a little graphic. I threw in stroke into this because I think it's really important anytime we talk about cardiovascular disease to talk about stroke. And just don't worry about this busy slide from the American Heart Association, but just look at the stroke death rates. It's all in the South. In the West, Northeast, and the far West, it's not so bad. So we have some work to do. This is also a little just composite of, and if you look at the bottom, you can see that darker is worse, and it's most of the high rates of cardiovascular disease correspond to the South. So we've got too much good eating, too much good food, and not enough exercise. And Louisiana, unfortunately, is the #1 most obese state in the union. So what's going to really get us from a heart standpoint talking about cardiovascular mortality? Well, it's really heart attacks. If you've got a plaque in your heart, it's inert, that's not going to be the problem. And the problem really in our society is that a lot of times we don't know we have a problem until you start having symptoms, and your first symptom can be a heart attack. Now the problem with that is that, as you see by this slide, in 1979 there were 134 deaths per 100,000 people and from a heart attack. Okay, we've dropped it down to 85, but really the slide kind of shows this is up to 2000, but the data is pretty consistent. Even in the 2000s, our heart attack mortality really hasn't dropped that much per 100,000. So the only thing we have to do is to worry about prevention, and that's really what I'm going to stress today. So, well, what is heart disease? What are we really talking about? Well, it's a thickening of the blood vessels with plaque. From cholesterol, oxidative stress, shear stress from high blood pressure. It's also a thickening and weakening of heart muscle due to high blood pressure. There are some other causes, viruses and inflammatory problems can cause that, but for the most part it's from high blood pressure. And then weakening of the blood vessels from high blood pressure, genetics, high cholesterol. You can develop aneurysms, have strokes, things like that. So, well, how does all this happen? Well, high cholesterol. Cholesterol is deposited in your arteries, and it is a reparative type process. In other words, when the cholesterol is circulating, the inflammatory cells pick up this cholesterol in the walls of your arteries and deposit it, and then the body tries to repair it over time, and that's what causes this plaque to form. Diabetes. Insulin is a growth factor for type 2 diabetics. Type 2 diabetes has to do with elevated insulin levels and decreased responsiveness to insulin, and this causes thickening of the blood vessel walls and acceleration of the atherosclerosis, the plaque buildup. Smoking. Smoking is a inflammatory problem that happens that accelerates the reparative need from your body with these inflammatory cells. High blood pressure. High blood pressure is an injury mechanism with shear forces of these arteries that over time causes weakening of these blood vessels, weakening of the plaques, plaque rupture, and then can cause heart attacks and stroke. There's also genetic locus that gives you an increased incidence of cardiovascular risk. We're just starting to really understand that. And in fact, if you go to 23andMe, you can send them a saliva sample and they'll tell you whether you have the 9p21 gene locus for coronary disease. And that's something else that may come to the forefront in the future. And also being a man, unfortunately, has in the past, and we thought it was testosterone and things like that, but male gender is a risk factor for cardiovascular disease. And here's a little movie just to show you about the artery, the blood vessels going through your arteries, and they carry with them the plaque, as you can see by these little bubbles. And then over time, you get deposition of the plaque against the artery walls, and then you can develop a restriction that will eventually cause symptoms. But the problem with waiting for symptoms to develop is that you've got years and years of plaque buildup before you even get there. Now you can see really in the Bogalusa heart study done by Dr. Gerald Berenson, gosh, I guess it was in the 60s and 70s, they looked at teenagers that had been in motor vehicle accidents or died suddenly and looked at their aorta and found out that even when you're 15 and 16 years old, you have fatty streaks that develop. And that's the beginning of atherosclerosis, even when you're a teenager. This process increases through time, and it's not till it's late in the process in your 40s and 50s when you have these complex plaques that you develop symptoms. So unfortunately, at that point, the horses are out of the barn, and you've already had a problem, and then you're kind of stuck. But it's not over. But it's very, very important to realize your risk up front. So, well, that brings us to kind of what really is a heart attack. What does it mean, and how is that different from blockage? And I thought blockage was a heart attack and a stroke was a heart attack. Well, a stroke is damage to your brain, and a heart attack is a sudden lack of blood flow to your heart muscle caused by a blood clot in the coronary arteries. So it's a blood clot that forms on one of these plaques. It causes irreversible heart damage, and it can ultimately lead to heart failure and death. Now here's a little movie, and you can see the plaque on the bottom here, and it has a cap on it right here, and that cap busts open due to shear force, inflammation, and then you get this big blood clot that forms in the artery. Now the thing that you'd notice about that is the plaque wasn't about totally closed in there. The plaque was about 40%, and that's the other problem, because most heart attacks happen in plaques that are not obstructive. So your first symptom may ultimately be a heart attack. So what are those symptoms? Well, in the movies you see people grabbing their chest and everything, but a lot of times the symptoms are much more subtle. You can have chest discomfort, usually in the center of your chest, but it can be in your back, your shoulders. It's an uncomfortable pressure, squeezing, and fullness. If it's pain, that's a heart attack. But what you have to understand is sometimes you'll have funny discomfort before you actually have the pain of the heart attack. So if you start having anything, and we really say when we're screening patients, from your belly button to the bottom of your nose, that's the area where really you can have discomfort. You can hurt in your teeth when you You can actually have pain in your teeth. You can have pain in your shoulders, the middle of your stomach. It's usually with exertion, usually will leave with rest, but if you're sitting around and you have discomfort and you start sweating, you get dizzy, and you're not having, and you're not doing anything, and that discomfort lasts more than 10 minutes, you need to be thinking about calling 911. So these symptoms are not necessarily what you would think. I mean, you can have this back pain, side pain, a little bit of stomach pain in here, and all that. If you get short of breath, dizzy with that, and have some other symptoms, then you need to be thinking about dialing 911. Because in heart attacks, one of the biggest problems we have is failure to recognize. And y'all may have heard of door to balloon time, where a patient comes to the hospital and then we whisk them off to the heart cath lab. Well, now we're really focusing in on encounter to balloon time, when the patient recognizes the symptoms, and that's really important. So, if you have a family history of heart disease and you have a lot of discomfort in here, it's okay to call 911 and let somebody do an EKG on you in your house and say, okay, you got a problem, or no, you're okay. So.
Is the EKG kind of the telltale sign?
Well, in 30% of a certain artery blockage, you can have a normal EKG, but if you're having discomfort, then you get somebody to come in, and the paramedics do an EKG now, and they're really good at looking at it, and there's certain criteria. But no, I mean, sometimes you can have a non-diagnostic electrocardiogram, but still, there are other things we can do to kind of sort out if you're having a heart attack. But they'll make the call and they'll say, look, you need to go to the hospital, and let them sort it out. Just some, and I wanted to also talk about the stroke warning signs. Here are some things. Just sudden numbness or weakness of the face, arm, leg, especially if it's localized to one side of your body. If you get confused, if trouble speaking or understanding someone, sometimes a stroke can be just, you're thinking of one word and another word comes out. If you have vision loss, acute vision loss, the eyes are actually part of your brain. So if you have vision loss that's sudden in one of your eyes, that is an absolute medical emergency. You need to go dial 911 and go to the hospital right at that time. If you're dizzy, sudden loss of balance or coordination. And the thing you have to understand is, for strokes, all these things, heart attacks and strokes, are very time sensitive. If you get to the hospital within an hour, there's an 85 to 90% chance they can give you a clot buster that will get rid of your stroke totally. If you wait after 90 minutes, the likelihood that you're going to get recovery drops dramatically. So it's very, very important to recognize these symptoms and then get some help. So, also a headache that sticks with you, especially with any of these other symptoms.
If you have a bleed, though, what do you think you do for that?
Well, the bleed can do the same thing, but what they'll do at the hospital is they'll do a CT scan immediately, see if you have any bleeding in there, and then if you don't have any bleeding, they will, they'll give you the clot buster. But yeah, I mean, if you got a bleed in your head, I mean, don't want to be negative, but that's a bad problem. Yes, sir.
What's the difference between a stroke and this thing that we here refer to as a TIA?
Well, a TIA is a transient ischemic attack, okay? There used to be 3 varieties, and I won't bore you with it, but if a TIA is symptoms that last less than 24 hours. A stroke is a permanent deficit. So if you have, say your arm gets weak, it lasts for about 2 hours, and then it goes away, and they feel like that's a neurological event, that's a TIA. But if you have, trouble speaking or weakness on your left side, and then and that symptom lasts over 24 hours, technically that's a stroke. There used to be this other thing called a RIND, a residual ischemic neurologic deficit, but I think they threw that word out. But suffice it to say, the TIA is short-term, the stroke is a permanent one.
You said left side, does it make any difference what side?
It doesn't matter what, it doesn't matter what side. It's, I mean, it can be either side. The thing is that a lot of times the amount of the deficit depends on how, what your dominance is. If you're right-handed and the left side of your brain is affected, which is your dominant side, that's usually a worse stroke. But if your non-dominant side is affected, a lot of times you can recover more quickly. But anyway, it doesn't matter. It's still really a medical emergency. And just to reiterate, the cardiovascular disease is usually only detected after symptoms develop, and we can do a heck of a lot of things before via risk evaluation and prevent your symptoms rather than wait for them to occur. And like I was saying, with coronary disease, almost 50% of patients diagnosed, the first symptom was a heart attack. And almost 40% of heart attacks are fatal. So that's not great odds. So what are the risk factors for developing cardiovascular disease? Well, smoking, high blood pressure, high cholesterol, a family history of this 9p21 gene locus. Although there are probably other factors, but a family history is important. Your age and diabetes and obesity, which actually goes along with diabetes. There's a measurement called the hip-to-waist ratio that is a predictor for the metabolic syndrome and diabetes, and we'll talk a little bit more about that. So, as far as diabetes goes, there is a condition called the metabolic syndrome, and that is a continuum with diabetes. Everybody says, well, I don't have diabetes. I'm insulin resistant. Well, the reality is that there's a measure of your blood sugar that is a 120-day measure called the hemoglobin A1C, and event rates start at normal, which is 5.7, and it goes up. All this is a continuum. If your blood sugar control is bad, then your cardiovascular risk is elevated. If your blood sugar control is good, then your cardiovascular risk is much lower. It also correlates, your cardiovascular risk in type 2 diabetes also correlates with the amount of insulin you take. And we'll talk a little bit more about that. But it is a continuum of risk, and insulin is the problem. And with this constellation of things that I'm going to show you in just a second for the metabolic syndrome, that's how we determine your risk. Like I said, obesity and diabetes go hand in hand. I'm going to tell you how we figure out if you're too heavy. And this involves body mass index with your waist circumference and hip to waist ratio. Now, I put this slide in here just to let you all know, because I go to my, I hear this all the time, you're so skinny. I'm like, well, I'm really not. So for a guy who's 5'10" and a weight of 175 pounds, his body mass index is 25. If he weighs 180, he's overweight according to the body mass index. If you're 6 feet tall and you weigh 185, your BMI is 25. And if you're 6'3" and you weigh 205, your BMI is 25. Anything more than that is overweight. Now, some other numbers. So if your height is 5'10" and you weigh 245, your BMI is 35. That's morbidly obese, according to the BMI calculator, a BMI over 35. If you're 6 feet tall and weigh 260, your BMI is 35. If you're 6'3" and 280, then your BMI is 35, and that would be categorized as morbidly obese. So I just want you to understand that, that most people need to weigh, most men need to be significantly less than 200 pounds and have a that will give them a waist of less than 40 inches, which is important. When I talk about a waist of 40 inches, that doesn't mean your hips. I mean, I see people all the time in clinic that have, oh, I wear 36-inch jeans and their jeans are down here. No, your waistline is just your belly button. And that's where the clinically, and I'll show you why that's important. So that's what I was saying. Anything over 40 inches carries with it elevated cardiovascular risk, and incremental increases in this measurement increase your cardiovascular risk. So now I talk about this metabolic syndrome. It is what's called the diabetic risk equivalent. And the reason that's important is because it helps us figure out what your cholesterol should be in order to prevent risk down the road. So, and we'll talk a little bit about that in a second. So, central obesity, high blood pressure, high triglycerides, low good cholesterol, and insulin resistance, and an impaired OGT. If you have two of those, then you have the metabolic syndrome. So that's how we kind of sort this out. And the belly fat is important in the metabolic syndrome because it's not inert. These are the problems. The belly fat is the storage center for the liver. And what it is it's an easy access place for the liver to get fat and energy in order to make different things it needs to make. But when you have too much in there, it overloads the system. You don't have enough insulin receptors to handle the sugar that's coming into your system. And so that's when your insulin levels start to rise. And what happens is you get this, what's called atherogenic dyslipidemia. That's high triglycerides with low good cholesterol. You have to think of cholesterol as a conveyor belt. The bad cholesterol, LDL, brings it out to your body and deposits it in the arteries. And then the HDL is the mechanism by which the cholesterol comes back and it scrubs the arteries out. So that's why it's important. Other parts of the metabolic syndrome are glucose intolerance, elevated insulin levels. And the other thing is that's so important about this is the pro-inflammatory aspect. Inflammation, as you remember when we were talking about how you get plaque building in your arteries, the irritation to the arteries is the problem. And as your belly fat increases, you develop the elevated C-reactive protein, which is inflammatory. You also develop what's called blood clotting problems, this condition called Lp(a) here. That is a lipid particle that makes your blood clot and also raises your blood pressure in about 50% of patients. So just a little quick thing about diagnosis of type 2 diabetes. You know, that's a fasting blood sugar over 125 or an oral glucose tolerance test where your blood sugar goes over 200. So, and the treatment for this is reduce your insulin levels with exercise and reduce your caloric intake and losing weight, because reduction in body fat percentage will make your diabetes, type 2 diabetes, go away. It's strictly a function of what your metabolic rate is versus what your body fat percentage is, because if your muscle mass is good and your metabolic rate is up, then your blood sugar is going to be good. And the other thing I just want to say, it's not necessarily how much you eat, but it's what you eat and when. Fasting is bad, you know, starches are bad, saturated fats are bad. All these things play into this. So, well, so having looked at all this stuff, what are, let's look at high cholesterol and how that fits into everything. So, HDL is the good cholesterol, LDL is the bad cholesterol, and triglycerides are kind of a function of this metabolic syndrome and how your body handles carbohydrates through your liver. And the other thing is that these particles are kind of a conglomeration, and depending on your genetics and things, your particles can be big and small, and you also can adjust those with exercise, supplementing with omega-3 fatty acids, and things like that. So the general lipid guidelines are for basically for everybody. We want your HDL to be high, your total cholesterol to be less than 200, triglycerides less than 150, and for those low-risk patients, a bad cholesterol less than 160, which frankly, if you're a man over 45, you're pretty much not going to be low risk. Moderate risk, which is probably where most men fall, is a bad cholesterol less than 130. Then the higher risk patients, the metabolic syndrome type patients that we talked about, that's where they fall. Their bad cholesterol needs to be less than 100. And then for your very high risk patients, patients who've had a heart attack, who have angina, their bad cholesterol should be less than 70. So, and then these are your modifiable risk factors. You know, with cigarette smoking, control your blood pressure, and low HDL mean that you have higher risk, and you have to have your LDL lower. So if you have a family history of cardiovascular disease and a male relative, first degree relative, brother, sister, mother, father, well, not your mother, but your father less than 55, then that's an additive risk factor. But the nice thing is they're looking at genetics, so you probably could look at a new gene test, and that'll help you determine this. Or a female relative less than 65. If she develops cardiovascular disease before she's 65, then that's an additive risk factor. So if you smoke, if your blood pressure's up, you have a low good cholesterol or a family history, each one of those gives you incremental risk and means that your doctor should have your bad cholesterol lower and lower. And there's the age at which, for men, it becomes a risk factor. Anyone over 45, women over 55. So, so a low risk patient, like I said, is a woman, non-smoker, with normal blood pressure, a good cholesterol, and no family history. Those are about the only people where you would tolerate a bad cholesterol greater than 130. But most people fall in more this moderate risk category, where you have like two risk factors. You know, if you're over 40, if you're a man over 45, and you have, say, no family history, you don't smoke, and you have treated high blood pressure, then your bad cholesterol needs to be between 100 and 130. That's if your good cholesterol is over 40. Higher risk patients is anybody with diabetes or the metabolic syndrome, and that would be a person with a bad cholesterol. They need a bad cholesterol less than 100. And then once again, the very high risk patients with a cholesterol less than 70. So I've kind of brought you through asymptomatic prevention, because I think that's really more important. But if you do miss all that and you are having some discomfort and things, well, how do we kind of sort that out? Well, your doctor takes a history and determine what your risk profile is. Do a physical exam, and it's very, very important just that that you have your blood pressure taken in your arms and your legs. That's called the ankle brachial index. If that's abnormal, that is a diabetic risk equivalent, and you should be treated like you have vascular disease. And they may even want to refer you to a vascular surgeon if you have pain in your legs. So that's important. It's also important to measure your waistline. If you're 40 inches, then that's another additive risk factor. Do an electrocardiogram. A baseline electrocardiogram, although you may have seen in the paper, they say, oh, in asymptomatic patients, an electrocardiogram is useless. That's accurate. But we're talking about people who have symptoms. If you have shortness of breath, some kind of chest pain or something like that, an EKG is an absolute must. And then at some point, you're going to need an assessment once you have a risk assessment of obstructive coronary disease. So you can see all we're talking about for these patients is finding plaque when it gets way up here. You know, chest pain isn't going to happen in these guys because you need a blockage of 70% before you're going to have angina. So this is way down the road.
Does that plaque and all ever disappear if you get all of this healthy living and doing all the things you're supposed to do?
15 to 20% of your plaque volume is mobile. So if you have plaque and you go there, oh my God, you've got all this plaque, and then you do what you need to do, either get on high-dose cholesterol medication or the Dean Ornish vegetarian diet or whatever that may be, then you can actually reduce your plaque volume by about 15%. But that's very, very important because what that does is, remember that vulnerable plaque that I showed you where it exploded all over the place? Well, that's the lipid core that's going to explode, that 15%. So you reduce that, your body heals everything up, your plaque becomes inert. You can live forever like that, you know. So how do we figure out if you have a blockage you know, when you come to the office? Well, frankly, I think a regular treadmill is pretty much worthless. You know, its predictive value is a coin flip. So get a quarter out, flip it. Heads, you got coronary disease. Tails, you don't. Okay. It usually requires having some form of echo or nuclear imaging on top of it. There's recently, and I want to talk about some of these genetic tests where they have this RNA polymerase stuff that they test, and they're a little bit later. And even in women, it's even worse. But in men, it's actually the test is a nuclear or an echocardiogram stress test is pretty good. And negative predictive value for those extends out to 2 years. Now, there's another test, and this is the best test for what we call negative predictive value. In other words, you know, if your doctor doesn't feel like you're really having angina, but you're having some symptoms and, you know, you're kind of on the bubble, and he says, well, I want to exclude a problem, then a cardiac CT and a calcium score has very high sensitivity for coronary disease, and it virtually excludes coronary disease with a calcium score of 0 and a negative scan. So that's why it's the real downfall of it, and I'll talk about it, is that it has spotty insurance coverage. There's also a new test for chest pain, a gene expression score. This is a test, and it only detects plaques that are only over 50% diameter stenosis, because as you get plaque buildup, you have these genes that are expressed, and they have a test that they can pick it up. It's gender specific, so it works well in women and men, and it has 6 gene expression terms containing 23 genes. Basically, they found these genes that are expressed in coronary disease, and they can do a blood test. As with everything else in life, there are pitfalls. It's only good when you get a 50% blockage. So you remember that picture. You know, if you're, you know, 40 years old and, you know, you have a negative test, then that's not really going to help you figure out if you're going to get coronary disease. So you got to go back to the regular risk evaluation, and you may even want to go back to 23andMe and have a screen for the coronary artery disease gene. You can't be on steroids or immunosuppressives. So if you have some lung problems or something like that, or you're on steroids, it can screw up the test. If you're diabetic, forget it. And also, if you have, if your C-reactive protein and your white blood cell count are elevated, you can't get the test. So I'm just saying that, you know, if you ever get one of these tests run, and then you get the result maybe you weren't expecting or something like that, or there were some, you know, there are some things that need to be looked at before you say, okay, well, I've got blockage or I don't have blockage or whatever. So now, just as far as imaging with this echo and the nuclear, the problem with those is you have to have a 70% blockage. So once again, you know, you're way down the road before you figure it out. And they're also more sensitive for multiple blockages. So if you have one artery that's blocked on the side of your heart, sometimes they can miss it. And even a cardiac catheterization doesn't mean you're low risk. This is something that people kind of really don't realize. You know, they say, well, the heart cath is a gold standard. Well, that looks at the artery lumen, the inside of the artery. You know, all that tells me is that if you've got a blockage, but it doesn't tell me what your plaque burden is. And you still can be at risk for a heart attack even with a normal heart cath. Remember, heart attacks most often happen in arteries with less than a 50% stenosis. So what do? Well, I'll just show y'all a couple of, this is a heart cath picture, just to let you know. This, we put a catheter, actually I've started going from the wrist. You can go from your leg, put the catheter up to your heart. You put contrast in the arteries. I don't know, can y'all see that? Let me run that again. I think I can. There. That's a little better. And that's the main artery coming out of the left side of your heart up here. This is your widowmaker, as everybody likes to call it. And then, and that just shows the inside of the artery lumen. A cardiac CT does a little bit better. And what it shows, you can see on this side, you can see all the calcium, and that's bad. We actually can image all the arteries. I think there's a better picture here. Yeah, this is your aorta, and you can see the plaque in this artery, and that may very well be plaque that's missed at a heart cath. You know, you might see this might look like it's pretty much open, but then and you say, oh, you're fine, and then you've got all that disease in there. The real good thing about a coronary CT, and this is the kind of picture you get, is if you don't have any calcium or plaque in there, then you don't have any disease, and your 5-year risk is very, very low. A calcium score of 0 actually can extend and assess risk up to 10 years, but you know, this is the advantage of this for excluding a problem. But still, it's very, very important to look at your risk profile and not rely totally on imaging, because you know, if your C-reactive protein is up and your cholesterol is up and you've got blood pressure problems, even if you've got a negative scan here at a younger point in your life, over your life you're probably going to develop coronary disease, and that's an issue. So, what do we do? Well, every man over 50 should take an aspirin, and that's the most effective means for prevention of heart attacks in men over 50. It's baby aspirin, 81 milligrams. We can argue, and actually the thing is that there are some people who are aspirin responders and some people who aren't. Peter Block came and talked to us. He's one of the gurus in this area, and there was a thought process that you could put an aspirin in your medicine cabinet, lick it once a week, and that's all you needed to do. But then there are the people who are what we call aspirin non-responders, and so that's where the argument for dosing comes. But 81 is fine. I've heard Dr. Oz say he takes 162. You can make that argument. Anything up to 325, you could really make the argument, although the recommendations say 81 now.
Is there an aspirin that dissolves faster than others?
Oh yeah, Alka-Seltzer.
Oh, Alka-Seltzer.
Oh yeah, that's one of my favorites. But be careful, because Alka-Seltzer, they changed the package. Made me. I had a patient. I said, "Yeah, go take Alka-Seltzer." Well, they started putting Tylenol in there, and so the poor patient was taking Tylenol, which does no good. Yeah, but exactly, come back with liver failure. But no. But be careful. But Alka-Seltzer is a great way to take aspirin, and you know, it's buffered. So that's a good way. But a coated baby aspirin is fine, and you know, and if it's not something that you need to get in quickly, you know, it gets it through your stomach, it's released in your intestines.
So you can eat pizza and take an Alka-Seltzer, right?
Absolutely. Slick things up. Yes, sir.
You said once a day?
What other medicines like aspirins have maybe a resistance against, not resistance, but they actually quit if you take other painkillers or whatever.
Yeah. Non-steroidal anti-inflammatories, that big group are the and that's kind of a whole nother talk, but you know, those medications actually impair aspirin's effectiveness, and also they can activate your platelets. In other words, you've heard about you know, these lawsuits about the Celebrex type drugs a few years ago and the risk associated with that. Well, all those Advil, Aleve, all that stuff works along that spectrum. It's just aspirin makes your platelets not work. Then the other drugs actually impair the platelets' ability to be affected by aspirin and things like that. So the bottom line is that they also can irritate your stomach and things like that. So you have to be careful about taking the non-steroidal anti-inflammatories and the aspirin, especially if you have kidney problems, you have blood pressure problems. You know, all this stuff can interact with your blood pressure medications and things like that. So,
Not to take Advil and aspirin together?
no, I'm saying that you need to be careful, and you need to you know, well, first of all, if you know, taking anti-inflammatories, if you're a lot older, and you know, usually if you're over 65, you know, most of the arthritis problems are more pain related, and so your risk with these medications goes up dramatically. The Aleve, the Advil, Mobic is another one that's prescribed. All those types of medications, but for people in their probably 40s and 50s and early 60s, it's okay to take occasional Aleve, Advil, but you just need to be careful. If you're taking, you know, if you're taking 2 Aleve twice a day and you're taking aspirin, you know, you're going to increase your risk for an ulcer dramatically by taking that baby aspirin every day. So you just have to be careful. Now, if you mix and match and you say, okay, well, I can get away with Tylenol and, you know, 1 Aleve a day, that's going to reduce your risk of having an ulcer quite a bit. Also, probably going to reduce your blood pressure.
I thought you meant to say that if you take an Advil and the aspirin, that the aspirin won't be effective.
Yes, they have an effect of interfering with the aspirin's effectiveness on the platelet. Yes, and so does Aleve, and so does Celebrex, and so does Mobic. But it's a spectrum. The Aleve is less than the Advil is less than the Celebrex.
How do the ibuprofen feels in that category?
Yeah, ibuprofen is one of the worst. It's next to, it's closer to Celebrex than it is to, Aleve is actually a little bit better than the Advil as far as interacting with the platelets. So, you know, I mean, but then again, you know, you need to be careful because sometimes Aleve works better for your pain than the Advil. Advil works better on your pain than the Aleve. So, you know, that's what you need to do. But understand that if you're just taking that every single day, that becomes a real problem. Taking an Advil every now and then, probably not a big deal. But I mean, if you're on that and you've got a, you know, if you've got some back pain or something like that and you're taking it every day, that's a problem, probably. So, well, let me just zip through and then I'll finish up the, I've got a little, I just want to tell y'all, I've got a couple little movies here. I just want to show you all about a stent. This is a stent in an artery, and we put a wire up, actually the way we did the heart cath, and put the stent across the blockage. You blow up the balloon, and then you remove the balloon, and the stent is left, and you have normal blood flow within the artery. And then the other is bypass surgery. This is the surgeons doing bypass, and what they do is they attach the arteries around the blockages. On this, they've got the heart, it's down in the hole, here we go. They've got the heart immobilized. It's actually called an off pump. There's the heart right there. This is the immobilizer. The arteries are here. And what they do is they attach a bypass into the arteries over here and reroute blood around the blocked arteries. So this is just, we talked a little bit about screening, and I just want to reiterate, you know, it's important to have these things done, a history and physical, an electrocardiogram, a fasting lipid profile, a fasting blood sugar, a high sensitivity C-reactive protein, and it's also important to get your carotids and abdominal aorta sizing and calcium scoring, especially if you have high blood pressure and the metabolic syndrome or a family history of an aneurysm. The other thing I want to share is you go to 23andMe. I don't know what the price is. It's somewhere between probably $300 and $450. They will, you spit in a cup and they send you this whole genetic profile, tell you what your ancestry is, your risk, everything, and they screen for the 9p21 gene locus. So.
.com?
Yeah, just if you Google 23andMe, it's 23andMe, and search it, and they have a nice thing, and they'll send you this kit, and you send it back. It's pretty amazing what you'll get, you know. And I'll just tell you, just to personalize it, I have terrible psoriasis, and and if you look at my profile, my risk for psoriasis is less than average. So, you know, it's like everything else. There are environmental factors that affect it, but, you know, it is interesting to look at all this, and because there's stuff like age-related macular degeneration. If you've got risk for that, you go take a vitamin every day and you'll never get it. So, but anyway, something about eating, then I'll take some questions. You know, these are some of just the general guidelines. If you inject fiber in your diet, the thing about my quick and dirty rule is if you pick up a package and it's got more sugars than fiber in it, that's a high glycemic index food. So if you look at something and you look at the fiber to sugar ratio, and if you want to have some fun, go look at black beans, pinto beans, all that kind of stuff, white beans, all those things, they have a lot more soluble fiber than they do sugar, and those are low glycemic index foods. Lean proteins in appropriate amounts, you know, that's where you get your cholesterol in beef and in high fatty foods. You know, avoid eating late at night. Also eat breakfast, you know, if you fast, and then eat. The first thing your body does is store your food rather than increase your metabolic rate. You've probably seen stuff in the media about prostate cancer and fat and fish oil and all this kind of stuff. I mean, I would take all that with a grain of salt. All this kind of retrospective stuff, it's still, there's so much good data about supplementing with omega-3 fatty acids that I think fish oil and flaxseed oil are a good thing to do. Even for general health, I do it. I like flaxseed oil. Consider a multivitamin if you're, you know, and niacin is good for high triglycerides and low HDL, which is your good cholesterol. Although the data in it against the statins is not as good as I would like it to be. You know, make sure you get plenty of green vegetables. Sometimes antioxidants are helpful, and antioxidants have been shown to be beneficial in cardiovascular risk prevention. And the other thing is, anything in a bag, be cynical about. I tell people, I say, look, I can go through Albertsons and go hit the fruit aisle and grab some lean protein before you get through Wendy's, and I'll be done before you are. So, and that's something good to remember. So, the other thing is that remember that stress is a risk factor. And actually, if you look at the American Heart Association website, they recommend yoga, meditation, and exercise. Something to think about. You know, be careful with alcohol because of calories and the cancer risk. Anything more than 2 ounces a day is excessive. And for alcohol, 2 ounces a week is where you derive any benefit that alcohol has. And the other thing is that exercise is nature's antidepressant, and it's 20 minutes 4 times a week, whether it's walking, treadmill, swimming, whatever you can do, very, very important. So. And I'll take any questions. Yes, sir.
Your alcohol percentage, is that alcohol or just a liquid measure out of your 80-proof bottle?
It is alcohol equivalent. So if it's 4 ounces of wine, 6 ounces of beer, 1 ounce shot of liquor. That's an alcohol equivalent.
And that's for the week.
Well, the benefits are.
Ounces of wine a week are.
Well, you can 8 ounces of wine a week is your benefit allotment. Okay, but anything more than 2 equivalent ounces a night is too much. And the other thing is that you have to, those alcohol is generally a sugar. It's like beer and wine are metabolized as a sugar. So that's a sugar equivalent if you're dieting. So if you're gonna, that's like eating a piece of bread. So you have to kind of understand that.
Well, you hear about drink a glass of red wine
Mm-hmm.
every day. What is that about? Why is that not good?
That's an antioxidant effect. And the skins of grapes are tremendous antioxidants. And that's what that thought is all about. But as far as the tannins and the skin of the red wine, of the grape, that's why they recommend they also said that it may increase your good cholesterol. But you know, there are all kinds of ways to increase your good cholesterol. I mean, you can take 2 tablespoons of flaxseed oil and go run on the treadmill for 40 minutes. So, yes, sir.
What's the problem with Aleve and certain blood pressure medicine, like Diavan? I was thinking Diavan, they tell that you have a problem with Aleve and Diavan.
Yeah. Yeah, they work on the same. They work on the same part of the kidney, and what happens is that it makes this artery constrict and can restrict blood flow to the nephrons. So when you put the Aleve in and the Advil in with your Diavan, it actually impairs its ability to lower your blood pressure.
You just take them separately, or you know, take one in the morning and one at night, or something like that. You need to take like Aleve at nighttime, or just don't take it at all.
Well, I mean, it affects your. If you take your Aleve and it's in your system, it's going to raise your blood pressure because it impairs your kidney's ability to handle salt.
Right.
So that's why it's a problem. I mean, you can take it, and you see, blood pressure is a risk. I mean, it is a risk over time. So if you take, you know, if your blood pressure is controlled, say 90% of the time, and then you take Aleve so that your blood pressure is only controlled 60% of the time, then you have an incremental risk over that time period. It's not that you're going to take the Aleve and, you know, something bad's going to happen, but it just sets you up for problems potentially. Yes, sir.
Good cholesterol, is there other things you can do to raise that cholesterol? Good cholesterol?
Not much. You know, really exercise and maybe red wine. And the thing is that I talked about big particles are better. Niacin makes your particles bigger, which makes your good cholesterol more protective. The other thing is omega-3 fatty acids actually make your particles bigger so that they're more protective. But as far as raising HDL, that's been the holy grail. There are some genes that they've identified the gene, but unfortunately, when they had a drug for it, the people actually did worse than the people who didn't take their good cholesterol was high, but they, you know, they didn't do any better. Same problem with vitamin D. They've identified vitamin D as a problem. I didn't really go into that, but the problem is that there hasn't been really good, I want to say, results with giving people vitamin D. You know, the people are still having problems with low vitamin D, so there's something we're missing in there.
Is there anything that would raise the particle size of the LDL?
Yeah, same things.
Same.
Yeah,
Nice and
it makes all your particles bigger. Yeah, and which is better because it has.
Is there a test to check for that?
Yes, it's a fractionated lipid profile. One of them is an NMR. I think Mayo Clinic has one, and it actually what's called fractionate your lipids, and you can see how big your particles are.
So if your particles are bigger, then you're better off.
Yeah, that's better. It's a function of surface area. If you think about having a big ball and having cholesterol in there, I may have small balls over here and big balls over here. If you've got the big ones, they have less surface area to interact with the blood vessel walls, but the small particles are full of cholesterol, so you have more net surface area to interact with the artery walls. So that's why that's more of a problem.
Do they do that blood test here at your office?
Oh yeah, yeah. And a lot of physicians do if you ask them. But yes, we do that at the office. Yes, sir.
How good is red wine extract?
I don't know. You know, these were studies. The red wine thing was something that was studied in the late 80s, early 90s with the Mediterranean diet, and that was what they hypothesized. But I don't know anything about red wine extract. Yes, sir.
Did you say that flaxseed oil helped your HDL?
Yes, it helps, it helps make your HDL particles bigger. But as far as you know, like I said, the red wine supposedly can raise your HDL a little bit, and as well as exercise. Those are really the only two.
It'd be a good thing to take flaxseed oil.
Yeah, omega-3s are a good thing to take, especially if your triglycerides are a little elevated.
How often you take it?
You take it with food, up to 4,000 milligrams a day total. Usually I divide it out, and I'll tell you the pitfalls. The fish oil makes you, you know, people feel like they're burping up fish all day, and that's one of the things they don't like. The flaxseed oil, I will tell you, if you eat flaxseed oil with your meal, you will be full for hours. That's the one thing. I feel like, I mean, it fills you up. So that's the difference between the flaxseed oil. I think I probably eat a little bit less when I eat the flaxseed oil.
You mix it with what?
Well, you can get it in capsules, or, well, you can do a couple things. What I do is you can put it in a shake. You can make salad dressing out of it. But I'll tell you, the stuff tastes terrible. Look, I'm not going to sit up here and flaxseed oil tastes terrible, okay? You can hold your nose and shove it down. You can put it, my favorite way to just do it is take a 4-ounce shot of orange juice and just shoot it down.
Put a tablespoon in a little glass of orange juice, pick it up and take it with my vitamins.
Exactly, and that's probably the best way. But some people actually will get sick if they take their vitamins and that flaxseed oil. You really need to eat something because it'll
right after that.
Yeah, you need to have some food on your stomach or you'll get nauseated. Yes, sir.
How reversible is heart disease?
Well, I mean, 15% of your plaque volume is mobile, but as far as, you know, heart damage and things like that, I mean, until we get stem cells to work, which may be the next thing, then you know, when your heart's damaged, you know, all you can hope to do is hold the line. But maybe in another 10 years, when there is some promise with stem cells, they can take stem cells out of your bone marrow, inject them in your heart arteries, and you'll make heart muscle.